most interesting part indeed, because we'll discuss now some clinical cases. You will present it. We have some Mentimeter questions, so once again, connect yourself to Mentimeter. It's done already. And it's very important that we will discuss together the case. As you know, for these cases, there is no bad answer, but it's a good opportunity for discussing, exchanging about experiences. You start? Go. It's a very interesting case, you'll see.
Sure. So, good afternoon, everyone. Good afternoon, everyone. Just a quick introduction of myself. I'm Abdulaziz Al-Mutawwa, one of the ICU specialists attending in Amiri Hospital. Thank you for your attendance, and thank you very, very, very much, Prof. Manat and Prof. Mano, for you being here. It's a pleasure having you in Kuwait City, and we are very happy you be with us. And I'm thankful for your great talk and presentation prior to my real case scenario. Yeah.
For some reason, the code, that's a code. I'm going to write it down for our court. 25696670, just the browser. You go to menti.com and you enter the code. Normally it's on every slide, but here probably something. So we wait. Who's trying to connect? We wait a little bit. Sorry. Normally, if you go to the browser, any browser, menti.com, as the URL, menti.com, enter. They ask for a code, 25696670. No, menti.com. Enter code. What is that? You're hacked. No, Menti, E, Menti, not Manti. Menti. We're struggling? Struggling to get online? So the code is 25696670. Enter. Enter the code. 25. No, just put 25696670. Join.
That's fine. Everyone's connected?
Everyone connected? Yes.
So, go on.
Yeah?
Everyone okay? Yes?
Okay.
The code.
So, I'll repeat again. Good afternoon, everyone.
5696670.
My name is Abdulaziz Al-Mutawwa. I am from one of the attendings ICU Amiri Hospital. Welcome, and it's a pleasure to have Prof. Manat and Prof. Mano on board, and we're thankful for their great talk. I think they definitely went through all over the literature, and they went into thorough details explanation that gives you a clue and hints on how to deal with the case scenario that we're going to present. Feel free to ask, because we're going to go through the ROSE phases. To be honest, this is one of the common case, but one of the challenges case that me, myself, I've learned a lot from this case, because it's tricky. We have to know how to approach, and most importantly, from now on, we have to really to be more structured in our approach, especially with these ROSE phases. From now on, I felt that approaching these ROSE phases gonna make our life more easier, and to at least approaching the basics into managing these patients, especially when fluid responsiveness or fluid resuscitation goes.
Computer sleeping.
Yeah.
We have to
okay.
resuscitate.
No, it's okay.
All right.
So,
Yeah. So we'll start with a ROSE concept. I believe the faculty has introduced the concept. Look at how pretty the rose is. We need our patient to be as pretty, as good as this rose. So as Prof. Manu took you over the rose module, so you have to ask yourself, do roses need more fluid to survive? Yes, we have to give them fluid, but not to a point that you have to be drawn, because they're gonna be, you're gonna see the different way in their outcome and management. So you hydrate your flowers and rose to a point, you don't drown them, make them dry, alive, but not dead with worse clinical outcome. Okay, so what do you know about rose phases in fluid management? And very quick brief summary, just to remind ourselves about the journey that all of us have to go and approach. R is resuscitation, optimization, stabilization, and evacuation. And if you can see the graph here, it goes with fluid balance or cumulative along with organ failure. So you have to match your fluid with organ failure assessment step at a time in a very good timely manner, from minutes, hours, days, weeks, and up till months. So this is a very quick reminder for all of us. Okay, so before we start the case presentation, we have to ask ourselves, what does R phase means? So it is a resuscitation phase. But if you go back and review the terminology, it says that the stage has to focus on patient rescue or an escalation, as we understood and took from the previous talks. So how we rescue the patient and how we escalate, we start with a case, and please interact, and if you have any question, go ahead. Okay, so this is Mr. N. He's 73-year-old gentleman with a BMI of 31. We can say he's obese, BMI more than 30, with the following background history or comorbidities. He's a diabetic, he's a hypertensive, history of proximal atrial fibrillation, and importantly, he had a background history of ischemic cardiomyopathy, he had a history of inferior myocardial infarction, where he underwent coronary angiography recently back on August 2024, and he had a drug-eluting stent into his right coronary. So as a sequelae or consequence, he had a heart failure with a reduced ejection fraction, okay, is as per last echocardiography on August, his ejection fraction is down to 30% with a diastolic dysfunction, and if you see here, there is a lot of like hypokinesia and akinetic areas in his echo findings, with normal right side systolic size and function. He had some major neuropsychiatric disorder that he takes medication. So he has no significant past surgical history of note. And this is his medication. He's on dual antiplatelets. He's on a beta blocker as a rate control in form of bisoprolol, anticoagulation for his atrial fibrillation, as well as he's on furosemide as diuretics at home. Okay, so starting with chief complaint. He came in to you, to the ER or emergency department at 2 a.m. early in the morning, okay? Complaining with a 3 consecutive days history of productive cough and fever with definitely he has a reduced, or anorexia, reduced oral intake. Symptoms, our systemic revision has revealed that he has short of breath and some orthopnea. He couldn't lie flat completely. Okay, physical examination would reveal that he was hypotensive, systole is down to 80 over 55. He's tachycardic despite being on beta blocker. Risk rate is up to 28. His saturation is down to 80%, up to 92 on 4-liter nasal bronch, which relatively, let's say, acceptable oxygenation at that point. His febrile of more than 38. Chest examination would reveal bilateral corsicruckles, but you heard more cruckles on the right lower lobe or right upper lobe zone. There is an obvious bilateral lower limb edemas. And if you go and do an initial modeling score, it was up to 1, okay? And the capillary refilling time was more than 2 seconds. Okay, going to the basic lab investigation and images at the ED. He has a leukocytosis. Creatinine is upper limit of normal. He has high inflammatory markers with high procalcitonin and C-reactive protein. If you see here, there is a highlight with high pro-BNP, it was 20,000, okay, which means that it's a significant high number. Negative troponin, his initial laxate was up to 6, okay? ABG was obtained, and if you see here, there is some element of metabolic acidosis with some compensatory respiratory alkalosis, or is trying to washing it up and compensate. X-ray has shown bilateral airspace disease, more predominantly on right lower lobe with a consolidative patch. You can see it's doubtful of, we're not sure this is pulmonary edema or this is definite pneumonia, but we agree based on his symptoms and presentation that might be a right-sided pneumonic infiltration and consolidation. Okay, so you are at the ED, you are at the R phase. You have to rescue the patient and escalate. So,
Back. One slide back. Yeah, oh, no.
oh, I'm sorry, how can we go back? Just, oh, from down.
Okay, here. What is the most likely diagnosis? Normally you should be able to enter something. So we just wait for... Yep,
Pneumonia, septic shock with maybe cardiogenic shock also.
What are the arguments for both?
Cardiogenic shock because the patient is cardiac and has stent and has pneumonia, septic parameter is high.
Indeed, we have some signs of infection, huh? And BNP is high, but it's not very specific, of course. And he's feverish, and the procalcitonin is high. So we see people think mainly about sepsis, pneumonia, but there is still a doubt about cardiogenic shock. How was the blood pressure, Abdelaziz?
80 on presentation, 80, 85.
Systolic and the diastolic?
50s, lower.
50, so it's not very low. Huh? So, as you know, it may indicate vasodilation if it's very low, but 50 is not very low. So I would be doubtful as well. Any more comments?
Cardiogenic shock. Cardiogenic shock.
You would be for cardiogenic. Other ones? Okay.
Okay. So all the opinions might be right, might be wrong, because he just presented with like probable diagnosis. We say sepsis, yes. Septic shock, still it's early to define this as septic shock. Cardiogenic shock, maybe. So you are in at the ER, we need to rescue the patients. So at that time, when a patient came, high-grade fever, high inflammatory markers, and he's hypotensive, despite of like doubtful background cardiac history, you are the attending treating physician or a nurse in the emergency department. What's your initial goal in managing this patient at that point? So A, B, C, D. What's your target?
Next.
Okay.
So choose. So early, adequate, goal-directed fluid management, organ support and maintain. It's a multiple result, right?
No. just
Multiple
one.
answer.
Just
Is it-
one.
Just one. No one votes for fluid removal at this stage.
Okay.
It's hard to choose between A and B, huh?
Both are
What's
valid.
your opinion?
Well, only in the sitting, I think I'll go with organ support maintaining TP.
You have to do something. He has something in mind.
So, do you have any supportive data to use leg rising? No, not this case, in general, because we brought up the heart failure. Do you have supportive evidence that we can use leg rising sign in patient with heart failure, left or right?
Very good point.
Very good point. In theory, it's the same. You can have a patient with previous severe cardiopathy But in case of deep hypovolemia, he or she may be fluid responsive and passive leg raising would be positive. Whatever the background and the past medical history, it will still indicate preload responsiveness. And typically, if it's septic shock, this patient may be fluid responsive. So that's what you would need, passive leg raising here. Okay. Who has another opinion? What's the right answer?
Well,
So the right answer is going to be A, initially.
A initially, so you would give fluid.
Yes, but with checking the response of the fluid, if his patient responsive or not, which this is why the case is in here. It was not solidly assessed or checked. That's why we have to learn of what to do in such cases in the emergency department or even in the ward or in the ICU. Okay? So
Who would disagree with the A answer? Who answered B and wouldn't change his or her mind?
well, you do A, and the
You
result of
disagree.
A
You
is
strongly
B.
disagree.
Yes, I disagree because you mentioned there is a difference between fluid responsiveness and the fluid tolerance. The patient is a cardiac patient with high BNP, and I think extravascular lung water is high, hypoxic PF ratio is low. So what?
Is a valid point. So this is a mixed pattern of shock. It's a patient with a poor cardiac function who has now has sepsis on top. So both are right and,
Yeah,
and correct,
yeah,
I
I
would
mean-
say, for this typical case.
yeah, sure.
So A, yes, but you check all the conditions. So I would say passive leg raise.
Because if it is septic shock, you need to give fluid. You agree with this? If it is indeed, and if it's not cardiogenic pulmonary edema, you need to fill out the patient. Huh?
We need to move on, otherwise we are not going to save the patient in time.
Sure. So we might agree that he might be septic initially, and in the emergency department, you need to rescue. So your goal, let's say, is A, early, adequate goal-directed fluid management. And you decided to throw fluid or to give fluid. What type of fluid you would choose initially? A, B, C, D?
Next. So albumin, starch, lactated ringer, saline. Now, but vote what you do today, not what you're going to do tomorrow. Huh? Okay, so everyone is convinced of balanced.
Okay.
But the albumin is interesting. Would you use 4%, 5%,
20?
20%? 20?
Who said albumin?
20%. Would you use it in bolus or continuous infusion? If there is a shock, according to the studies by Robert Hahn, yes. Well, it's not 1 versus 4 volume expansion effect. It's rather 1 versus 1.2, 1.4. So there is.
It's slightly more efficient, but not that much, especially in septic shock.
Okay.
Okay. Sodium chloride.
I'm sorry.
Yep.
Yeah.
No, we're happy. If you want to go back, you just push that one. Yeah.
Okay.
Okay. Saline, yeah, I think in reality it's probably more because we asked previously what are you using as isotonic solution. So, but it's good. It's the mindset that is changing. Perfect.
Okay.
Move on.
Moving to the next, I'm not going through the details of the literature between choosing colloid, crystalloid, or what type of is balanced or unbalanced, but in just a quick hint and brief summary, all of the NICE guidelines, the British consensus guidelines in fluid and surgical patient, as well as the SALT-8 trial, will be all in favor to go with balanced crystalloid because it has lower hypercolonic metabolic acidosis on all of, and lower incidence of AKI and mortality. And this is the latest systemic review and meta-analysis to compare between balance or saline, as well as the PLUS trial that at the endpoint, that might not be a huge difference between both, but they're all recommendation that you go with a balanced crystalloid to start with your fluid resuscitation and management an ER patient or any sick patient who needs a fluid. Okay, so we are still within the trigger, okay? You decided and you ordered to give a balanced crystalloid at that point, okay? What is the most appropriate next step in your management between A and D?
I remind you that the Surviving Sepsis Campaign recommendations corresponds to the A answer, as you know. 30 milliliters per kilogram within the first 3 hours. Okay. There are some very conventional colleagues for the SSC guidelines. A majority for 4 milliliters per kilogram.
Remember, the ejection fraction was 30 or?
Initially. And he has a very high PMB and we're not sure.
Yes, go on.
Go on.
Yeah, we may
Yeah,
be
I'm
there.
sorry, I go away from that. Sorry. Yeah. So as we mentioned, cardiomyopathy, some low ejection fraction, high BMB, we're not certain this is pneumonia or pulmonary edema.
So the majority is for a dynamic trial of 4 mL per kilogram.
Okay. I might not disagree initially to start with, because if we move on and we would think more and more, one of the options, would you start for this patient specifically, or would you initiate an early norepinephrine at that point? Giving a fluid that we are debating about the how much you would give or how much the rate, but would you start norepinephrine at that point? Yeah?
Yes.
Who says yes? You would, for which
I mean,
arguments?
you
Why
gave-
no? It's very early, huh?
It is this patient high risk for fluid overload and more fluid complication. So early start with norepinephrine will be beneficial for the patient.
True, but if you look at the criteria we suggested, it's not a recommendation, for deciding to give early norepinephrine with Daniel De Backer, we have no indication for a very low arterial tone in this patient. I mean, the diastolic blood pressure is not very low. It's the only reason why I would hesitate before starting norepi early. I would need a strong vasodilation telling me the patient will respond to the vasopressor strongly. You understand?
Mm-hmm.
But it's true, there is a risk for fluid overload, definitely.
Yeah.
The patient is cardiac. How I will start?
The patient is cardiac, yes, and?
Will I start norepinephrine in this case?
Yes, it wouldn't change my mind. Perhaps it's even better to restore blood pressure rapidly to perfuse the coronary arteries.
Failure, I will start by dobutamine or milrinone.
So you would start for a inotrop now. Would you agree with this? I would not start a inotrop right now. You know, we have no echo. We have further, perhaps. Because you're afraid of a too strong increase in afterload? That's the reason why? But you know, afterload for the moment is low. Huh? The patient is hypotensive. And you know, afterload, it's systolic arterial pressure. So for the moment, it's low. So just restoring systolic blood pressure means you do not increase afterload too much. You understand? Provided the patient does not become hypertensive. So for the moment, I would not mind giving norepi. Afterload, you just restore afterload to its normal level, not higher. No need to start? That's all the debate. Would you I think I would start it now for sure if the patient would be very vasodilated, with a very low diastolic blood pressure. Here I would hesitate again. So I would give fluid and perhaps look at the response of blood pressure. Indeed, for the moment, we did not assess any response. You're right.
So this is the, triggers. We're triggering because this is what initially back in with our team, we're thinking retrospect, we do such management or we debate. So it's always debatable, and it's not easy, especially when a patient came into the ER or emergency department acutely, where you are assessing and you are allocating his background history and his presentation. But it's starting with the fluid rate and how much infusion rate you would give. It's like, as mentioned, it's all based on observational retrospective studies and adopted or adoption in literatures and any great, solid evidence. We're not sure. And you can see it's heterogeneous between clinicians. Some will give liter, some can have, some less, some more. So it's variable, okay? And even, in the Surviving Sepsis Campaign latest recommendation, you give a rate of 30 ml per kg of ideal body weight, but it's not very strong evidence, weak recommendation and low evidence. So we still have to debate about the exact amount, and it has to be individualized initially on your resuscitation phase, okay? And just before going to other question, we have to differentiate between fluid bolus and fluid challenge. Fluid bolus, that you have to give fluid, and the fluid challenge, you have to assess the response of this fluid that you've given. Okay, so again, we are within the clinical trigger, whether we start the fluid or we don't start the fluid, on how much and how we assess. So based on the fluid challenge you've initiated now in the ED, what is the most appropriate guidance or test that you have to do to assess the fluid responsiveness on spot?
Can you click?
Is it to assess whether the patient is fluid responsive or to assess whether the fluids given in the dynamic challenge were effective?
Yes, if it's effective or if there is a dynamic challenge that predict that the patient would be responsive at that point.
Before giving fluid?
No, after.
No, after giving fluid.
So it's a dynamic fluid challenge.
Yes.
So you gave fluid and you want to assess the response,
Yes.
right?
That's a good question. It's,
Because realistically, we're going to go and see that the scenario going to continue, and then we're going to see what has to be done more appropriately at that stage.
but the right answer is not there. Maybe. So Xavier, would you do a passive leg raise before and after you give fluids?
After, no, because
No.
if you give fluid, the best way to assess fluid responsiveness is just to measure the effect of that fluid bolus.
Yeah, sure, because this is the question is that already the challenge has been, you gave the fluid. Already
That's the best challenge,
Yes,
huh?
if given. So how to assess the fluid responsiveness dynamically? This is why I'm asking.
Agree, but then you need cardiac output because by definition, fluid responsiveness is an increase with 15%.
Sure.
And there is no,
There is no.
There
at
is
this
no
point.
answer
There is no,
like
I
that.
mean,
Yep.
even in this case, just to think out loud, because was it
okay.
done?
Nevertheless, I think that if systolic blood pressure, or even better, pulse pressure, increases a lot during this fluid infusion, it would mean that cardiac output has increased.
Yeah.
But
With lactate.
with the lactate
That
decrease, but
decreases.
it takes time to look
Yeah.
at lactate.
Yeah, because this is what's next in here. Because to me, exactly, we're not certain what has to be done at
You're
that
right.
point. We're collecting the data, and we have to go with the conclusion, the best action.
The
evaluated.
patient is not intubated, eh?
No, not yet. He's still in the
Spontaneously
ER,
breathing.
in the emergency department. Okay, so realistically, what happened? You are still in the ER or in an emergency department. Blood culture was obtained, and broad-spectrum antibiotics were started. Okay, the patient received a liter of a crystalloid with an albumin. Okay, and blood pressure from 80s, 80 plus, it went up to 107, almost more than 90 or 100, with systole remained less than 60. His less tachycardic, not that much different, but at the time, his oxygen requirement may be higher with 6 liters face mask. You have repeat lactate, and you requested a lactate repeat. Meanwhile, you decided in the early morning, after like maybe 2 hours, okay, to transfer the patient and to be admitted to the ICU. Okay? So my next question, okay, just this is like not reality, this is just to test what you think. Okay, the laboratory department has called you and mentioned that at that point, lactate testing is not available, okay, or it's not in there yet, you have it done. So what's your alternative? Would you rely on the peripheral perfusion targeted resuscitation? What I mean, would you do capillary filling time and Mottling score as part of your peripheral perfusion assessment if you don't have lactate? And if there is any difference between lactate clearance at that point and these two scores and measurements? Any?
Yep.
No.
Is it-
So from that,
There is no voting for that question. It's an open question. And I think if there is
So-
no lactate,
no.
the Andromeda
There-
study showed that
There is
capillary
no-
refill time is maybe also
Yes,
valid.
it's true, but usually we have lactate. Who will stop measuring lactate because of the Andromeda shock study? Okay? So the practical consequence is that we should measure CRT for sure, but not replace lactate by capillary refill time. I
Sure.
think this is senseless. Huh?
Sure. So moving to the optimization. So the patient, okay, so terminology-wise, now it's your task to organ rescue and to de-escalate. So you are in the ICU at a time. At 8 a.m., after let's say 2 hours, okay, his blood pressure dropped again to 80/55 or 54, with a heart rate of back more than 100. Okay, his respiratory rate was up to 32, and for increased work of breathing, he was placed on high flow nasal cannula of 70% with high flow, and of flow 60. At 9:30, in 1.5 hours almost, or 90 minutes, his blood pressure was low and dropped again. Okay? The patient was awake, but looked lethargic and he was drowsy. Okay? So his abdomen, when you examine, looked or felt a little bit distended, a little bit in panic, maybe some subcutaneous edema of ascites at that time. Okay? We've asked to measure the intra-abdominal pressure, and it was initially up to 14. Okay, 14 means it's not normal, it's high. Okay? The urine output at that time on examination it was down to 20, but it's early to decide about his fluid balance at that moment. Okay. So we repeated his labs again. He still has leukocytosis. His creatinine start to go up to upper limit of normal, up to 1.7 and or 1.2 or 112. High inflammatory markers, and his BMB is higher at that point. Troponin remained negative. Lactate went down from 6 to 2, or 6.8 to 2.8. So what's the most likely diagnosis in here? So what do you think is going? I'm sorry.
So what's your diagnosis now? You know that lactate has decreased, creatinine is increasing, and BNP is high. And intra-abdominal pressure is 14, which is slightly elevated, right?
Was multiple organ failure. Cardiac, respiratory, kidney, and the gut.
Multi-organs.
All failing.
Dilemma, I love the answer. It's a pulmonary dilemma. Why did you measure abdominal pressure, he's asking.
What? In? Yeah,
It's not
so
ventilated, and why did
so
they
why-
measure?
Why you-
what's the problem? Sure. Absolutely.
We do. It's even the conscious patients and non-intubated. If you think you are going toward fluid overload,
No, the condition is that you mustn't have active abdominal muscle contraction. And the only reason when you do that is if you're a COPD patient and you have forced expiration. In all other situations, you can measure it. So abdominal pressure goes up with inspiration, down with expiration. If it's the opposite, then it's not valid. But even in spontaneous breathing, we've done some studies in non-invasive ventilation, it's valid. But you're right, and I'm very happy you asked the question, because we are now revising the consensus definitions, and we're gonna leave that out, because there's a lot of misconception that people think the patient should be intubated, sedated, curarized, and only then you can measure the abdominal pressure. Okay.
yeah. So move on.
Yeah, we need
Okay.
to move on.
So now
Yes.
it's a time of from clinical trigger to monitoring, okay, which means they are in optimization phase. So you are attending, treating physician or nurse in the ICU. What is your initial goal of management for this patient at this stage? You think there is cardiogenic or not sure, multi-organs? We are within the optimization phase.
How far are we from admission, Abdelaziz?
I mean,
Day one. Huh?
it's day one. I mean, after
Quite.
few hours,
3 hours.
3 or yes.
There's a comment here.
Yeah. From the start, we need further assessment regarding systemic vascular resistance, regarding cardiac output, regarding wedge pressure. If we find it all from the start, it will be different management plan.
Yeah,
If we know from the first point how much systemic vascular resistance, how much capillary wedge pressure, how much cardiac output, we will go in another way. From the start, when I told organ support, after assessment, if we do proper assessment, we will go in proper plan. That's all.
Continue.
okay. So, as you mentioned, you need further data and assessment for his dynamic test or dynamic testing, but you're still in the dilemma with diagnosis and what the measures. That was at that point we don't have a solid measurement done yet, and he's hypotensive. So you are within the optimization phase, beyond the resuscitation. So what's your aim and target for this patient current fluid balance? You want to keep him positive, neutral to negative, or negative at that point? What's your target? Remember, he just admitted maybe 4 hours from AD to ICU. And we gave fluid. He was shifted to ICU, high BNP, lower lactate, some increased work of breathing, and renal abdomen. So giving him positive at that point, not sure, no, maybe, okay. Neutral, okay, we're toward cardiogenic or cardiac failure or pulmonary edema, but there is sepsis. Maybe he has a combined type of shock. I don't know. So neutral to negative.
Yes,
So-
I know, but would you give diuretics to this patient now?
So this is again the question. Because
What is his intravascular pressure?
Volume.
Volume, intravascular volume, how would you estimate it? With what? Another assessment with what? Echo, why not? CVP, perhaps? Thermodilution, so cardiac output monitoring. So you would need more information. You would need more information. Sure. I would agree with this.
But the lactate was decreasing, eh?
Yeah, that rate
True.
decreasing. Yeah, he's hypotensive. Yeah, as you mentioned, you have some dynamic measurements and tools in front of you to decide. But you are now on spot. You want to more optimize, and you want to just, as Prof. Manat say, would you give diuretics at this point? Because his work of breathing is more, his requirement of oxygen is more, lactate is less.
I would intubate. Huh?
Is he still volume responsive or not? That's a good question.
Yep,
No,
yep.
no.
It's just a real case, you know. These
Why
things
don't you
happen.
do a lung ultrasound, bedside lung ultrasound, just to roll out the pulmonary? It's a simple test to do that, right?
Yep, do the
It's
check
the
for
guy
B
who loves
lines.
ultrasound, this guy.
Oh, monitor asleep.
So many people say we need more to answer. Huh? We need more information, lung ultrasound,
Cardiac
intravascular
output.
volume with echo or thermodilution. You said? Mixed venous saturation, delta PCO2 measurement, so okay.
Yep.
Perhaps we need more.
So a lot of a question that I'm happy that it triggered
Very
goes
good,
up.
very good. Yep.
Because this is the message from this case, okay? You have to do it to the maximum. And we're thankful this rose is like the time to review ourselves because we should not miss this point or this case, okay? So you, based on your answers or previous answers, okay, what is the most appropriate next step in your management? Do you want to give his hypotensive as mentioned, okay? Do you want to give fluid challenge with 4 ml and ongoing assessment of response? Or you should initiate norepinephrine at that point, prescribe albumin, just repeat lactate and the central vein saturation as simple. What are you going to do?
It's a one answer question,
Yeah, just
right?
one.
Yes. Maybe we should, diuretics, which is out of equation now.
And intubation.
Intubation, yes. Intubation, yes, for sure. And I don't want to say what happened, and you're going to be surprised. Okay.
Initiate norepinephrine, the majority is for norepi. Would you agree with it?
I would, but with an assessment of fluid responsiveness and more measurements in front of us.
Yes, I think
And-
that that's important. It's time to assess fluid
Yes.
responsiveness. I think here we should not give fluid like this
Yes.
without predicting the response,
Yes,
right?
yes.
That's what you
We,
mean.
we,
Sure.
and we might initiate norepinephrine at that point when he's critically ill, when he arrives to ICU. So here's the continuation of the case. So I don't want to say unfortunately, but he was given at that point 1 liter of crystalloid with an albumin, okay? By the whoever attended at that time. His MAP remained low, and then you decided, okay, let's have him or let's start on norepinephrine, which is I don't say high dose or low dose, 0.15, which is low to intermediate dose.
So it's 1 liter too much.
Yes. So he required higher support, and prior to that, he was given fluid. Do we have a data rather than echo, which we're not sure we could rely 100% or not, that showed more or less lower ejection fraction, cardiac output not too amazingly great, with collapsibility index of 5 centimeter with dilated IVC more than 2 centimeter. His lactate remained negative. I'm not sure why. Lactate is 2 at that time. And his urine output, not too great initially. Meanwhile, they told us that his blood grew MRSA bacteremia that goes with maybe vasoplasia, he's septic. There is an evidence that there is infection in his bloodstream At the same day, it's alarmed without time. And probability of MRSA is there. So back to the patient. Still, there is, so many things to address earlier and to handle before we go further. Okay, so back. This is the repeated slide. So at 6 p.m., after a few hours, creatinine rose up to 143, which is higher than the one that he came in. Fluid balance, still early to have a cumulative fluid balance, but unfortunately, the same day in the evening, he couldn't tolerate the higher support from high flow nasal cannula. He was more tachypneic, hypoxemic, so he has to be intubated and mechanically ventilated. Look at this chest X-ray. If you remember the first X-ray, there's some maybe pneumonia or consolidation patch. That might be more worsened airspace disease. Very much impressive on the right lower lobe. So this is progressive pneumonia, this is pulmonary edema, cardiogenic, septic shock.
Would you go for a CT scan, by the way? No? I
Why?
would. First, because it's a starting point when we will re-evaluate the lung injury. And second, it may tell you something about the pulmonary edema, yes or no, okay, depending on the aspect of congestion and infiltrates. So I
Maybe
would,
it's
but
pleural effusion. I would do ultrasound first.
Yeah.
Maybe then.
Yeah.
It's too unstable.
He's that way, I just pause and think what's going on here.
Okay, we stop here.
So still we are triggered and we have to monitor very many questions in mind at that point. So he's still on, we're optimizing. He's still on optimizing phase that we have to carry on, and we do these questions. So you have, at that point, ask yourself. At the O phase, you shall pause and rethink, okay? What we missed, what we should do better, and what we should address the case maybe more way earlier than at that point and at that stage. So query, question, decision to give fluid. If you decided to give fluid, you always have to protect fluid responsiveness. That was not done properly, or the way it has to be done. And if you ask, you have to ask your question at that point. Should I stop fluid? He was given 1 liter earlier. So should I stop? If you stop fluid, you have to think, is it the time for early vasopressor and albuterol? Okay? And this is a good opportunity for you to think about, now we have to prevent fluid accumulation syndrome. Stop unnecessary fluid. Okay? If you don't, if you're not giving diuretics because you're not sure, but don't give fluid. Prevent FAS, or fluid accumulation syndrome, and fluid overload. Okay? At that point, the patient was intubated already. So based on the decision, you go and you think and review the literature and the data. I don't think so I have to go all over the literature.
You have 15 minutes to save the case. You have to
Okay.
speed up.
Okay, so we'll move on
Yeah,
by
we
Dr.
know that.
Prof. Monet, great talk. So the tools already we've given the lecture and the hands-on simulation. So this is what we think going most likely in this case, which is CARS. What CARS? CARS means there is a cardio-abdominal renal syndrome that the patient is most likely is fulfilling these criteria. Okay? CVP, high CVP, I don't have a definite number to be honest, but let's say it's up to 18. He has higher intra-abdominal pressure and he has an acute kidney injury. So should he fulfill this criteria of CARS? Probably yes. And this is what we have to remind ourselves. Not always acute kidney injury is related to sepsis or septic shock, but so many literatures have reviewed that worsening renal function, it could be from cardiopulmonary, cardiorenal as in decompensated heart failure patient, because the venous, the renal venous is congested, so the flow is less. That's why they go into acute kidney injury, especially in this case. Okay. So
That's the reason for abdominal pressure, because it may be the missing link to understand why kidney function is worsening in a patient with known. Sorry?
Yes, yes, yes.
Maybe not, because increased abdominal pressure may have an impact on your venous flow. So we don't have any validation study of VEXAS in patients with abdominal hypertension, so far it's only in CABG.
But,
Yes.
but clinically in here, let's say the patient or he has lower lymphedema, he's in shock, AKI, intubated, he has some ascites in his abdomen.
Forward failure, backward.
Sure.
It's a combination, forward and backward. Yeah, yeah. Ilias?
Yes, it could be one of the processes in
The
septic
studies that Wilfried Mullins did, but we have to move on, was a threshold of 8 millimeters of mercury. Abdominal pressure was predictive for worsening renal function.
Okay. So moving onward, so should we consider albumin at that point? I'm not going to review the details of the literature. So the Albulus trial has documented there is a safety profile as equivalent as crystalloid as a volume expander. And there is ongoing large RCTs in Italy, which is Albulus Balance, to prove the efficacy and the, how much we could utilize and use albumin at that point. And you know, this is even an ongoing dilemma whether restrictive or liberal. Could we restrict the fluid initially or not? This is all have like in 90-day mortality, whether different or not, all in favor to restrict the fluid initially, not to go higher and initiate pressors as tolerated. And even, you know, the early, as I mentioned, there is no huge difference between restrictive and liberal, but the recommendation you go to restrictive fluid initially. And given the answer of, it's already discussed whether early start vasopressors. This was of the meta-analysis and systemic review that say if you start early pressors, it might decrease short-term mortality. There's shorter time to achieve and to target a MAP with less volume of IV fluid. Whether it has a mortality difference or not, it was not clear. It needs more studies and higher or larger RCT to prove it more much. So you might just say it's individualized, every patient different than others. Okay, I like this study. It's a retrospective cohort study in China back in 2015. They tackle the optimal fluid resuscitation when you resuscitate patient with septic with decompensated heart failure, looking at the graft, looking at the characteristics, looking at the outcomes. Okay, they've just concluded that the more you go with more 15 to 20 ml per kg of ideal body weight in septic cardiogenic patient or decompensated heart failure, the risk of ICU stay, ED admissions, hospital length is all higher, and the risk of being mechanically ventilated, intubated is even up to more than 50-52%. So you have to be very careful into, if you suspect or you've proven this is a decompensated heart failure, be very, very restrictive, and you have to give fluid with care and ongoing assessment and monitoring. Okay. So now we are on the S phase, which is stabilization phase. So stabilization phase means you have to de-escalate and you have to organ support. Okay, so back to our patient next day. Okay, so he was intubated and sedated with a RAS -2. Okay, his blood pressure, let's say, number-wise better, with better MAP and less norepinephrine requirement. His lactate is normal. Respiratory-wise, he was still intubated, requiring highish FiO2 with a little bit higher PEEP, with a control to support him. X-ray shows still extensive bilateral air-space disease. GI, he was already started on feeding through NG feeding tube. And GU, his creatinine keep worsening up to 190 or 2.2 milligram per deciliter. He has an evidence of metabolic high NN-GAB metabolic acidosis, where he was started and supported with sodium bicarbonate drip in a rate of 50 cc or 50 ml per hour. So he was given, just to keep in mind, a fluid that is infused. Okay, his urine output, let's say, relatively maybe better, okay, with better perfusion maybe. And going back to the review, he's 2.5 positive for the last 24 hours with lower albumin. Okay. He's still febrile. He's already on antibiotics as appropriate with the vancomycin to tackle his MRSA. he still have pitting edemas. So what is your goal in management in this patient? He's still intubated, low lactate, and better norepinephrine requirement, kidney function is worsening, and he's on IV fluid, like let's say for antibiotics, sodium bicarb infusion, feed.
Again, you do not know anything about preload responsiveness or more echo data?
No.
That's it, okay.
That's why
So the majority
the
votes
case
for
brought up, just because.
conservative fluid management. That's it? The
Yep.
majority of the answers? I'm quite surprised. I would think that people would like to remove fluid now.
Patient
What
is
they mention
doing
on
better.
conservative, okay. You are, remember, you are in the stabilization phase, which you have to think of de-escalation. You see his numbers now. His kidney, his background condition, his lung, lower lactate on his off hemodynamic or minimal hemodynamic support as comparison. Okay, we agree he's still febrile, but he's on appropriate antibiotics. And I didn't list these facts. A day or two, his sepsis markers got better with lower PCT on procalcitonin or the stuff. So fluid management here, we need definitely some dynamic assessment and tools, but whether you give fluid, remove fluid, you start thinking in stabilization phase, now you have to start think fluid removal. This is the message in this phase. Whether the patient requires or not, this is the trigger, and this is the dilemma.
So the end result on the cumulative fluid balance should be neutral. Whereas with goal-directed fluid removal, you want the cumulative fluid balance to come down. So your daily fluid balance needs to be negative. So in late conservative fluid management, either use restrict fluids, but sometimes to achieve this, you need to give a little bit of diuretics
Sure.
to it. So it's an overlap.
Sure. So this is what we are asking here. So what is your aim at this point or his current fluid balance? Negative or neutral to negative? Okay. We might agree or disagree because we say he is still on the stabilization phase. We're still not yet reaching evacuation phase. So neutral, negative, negative. Okay. We didn't reach the last phase yet. yeah, you're. Yeah.
But you know there are 4 options because there are 4 phases and they are always chronologically, so you can guess what he wants us to vote. Yeah.
I want you to vote on what you do because he's still not out of.
Okay.
Yeah.
But you know, we have 5 minutes to save the patient, then?
We're already finishing. Okay, so does patient need fluid maintenance? He doesn't need fluid maintenance because what he needs, we eliminate all unnecessary fluid, but he's on feed, sodium bicarb that was discontinued, whatever antibiotics, we have to make sure if you can give it orally, but at not a stage. So this is what you think. Would you give or you think fluid removal or diuresis? I might, if we have a limited of time now, we say yes. This is the time you have to start diuretics to further remove fluid to neutral, maybe.
No, I can agree to
Something.
disagree. So we said diuretics when there is FAS syndrome.
Yeah.
Syndrome is organ failure due to the fluid accumulation. Here, I'm not sure. Cardiac is doing better. Respiratory is doing better. Renal is not doing better. And the gut, I don't know. You started enteral feeding, but maybe it's not passing. So the kidneys would be my major concern with the VEXUS and all the other things to remove.
For a purpose, that's why I tackled this case, because in the stabilization phase, what we face, what's the difficulty in his case, it's difficult to wean and extubate.
Okay.
Weaning was a very challenging. He failed the SPTs because we think that his lung is not cleared yet, and he's still positive.
Then maybe not diuretics, but POL treatment.
Because there is no, he has high anangab metabolic acidosis and acidemia, which is non-lactic, and he has no GI loss, so we thought this is from acute kidney injury, and he was acidemic. We want to support him to be out of acidosis. And it was like a short course, and we stopped it soon after he corrected himself. Definitely.
Sodium.
Sure, this is what happens in this patient. We stopped it soon after we realized he doesn't need fluid, and he became hypernatremic here. Okay, so FUS, or is the patient at risk? Would person agree? Yes, he is at risk for a fluid accumulation syndrome. Okay, based on definition, he's positive fluid balance.
3 minutes.
Okay, 3 minutes. So we have to go to the last phase. Okay, the evacuation, which is, yes, you focus on de-resuscitation as tolerated and organ recovery. Okay, so in like 4th to 5th day, okay, the patient on minimal sedation, he's awake, okay, hemodynamically holding okay with good map, off norepinephrine, normal lactate, okay. He fails weaning trials, he's remained tachypneic, he needs higher support, okay. He's still on his gastric tube feeding, creatinine still creeps up, okay. Accumulatively, he's positive and he's hypernatremic at that point. Prior to that, he received diuretics, but I cannot answer whether he has the diuretics test, he passed it or not. We're going to see in the next slide, okay? Which, yes, so in this case, what is your goal of management?
Okay, fourth
I see.
option.
Okay. So you aim into late goal-directed fluid removal.
Yep,
Okay.
we do.
Okay. So what is the current fluid balance you require here? Negative. So this is the evacuation phase, and you tailor definitely your patient's different than others. You have to tailor according to the patient. Okay. For this patient, should he need more diuretics or to continue more diuresis? We did, I can tell you, we gave him a diuretic test, stress test, and he responded greatly. His urine output was up to 200 and plus in next 2 hours, okay, at that stage. So he passed the test, okay, and he remained stable hemodynamically, okay. So we gave diuretics, we went up to like higher dose, and we think he has fluid accumulation syndrome based on his clinical situation and scenario. Okay, we start to remove more fluid because he's hemodynamic stable. We have to do fluid responsiveness test at that point to check his response to make him more negative, and he's clinically and biochemically seems to be perfused. Okay, so we gave fluid challenge, or sorry, diuretics first semi stress test, and he passed it. Okay, but here is the role of albumin. His albumin is 28, I remember.
Yeah, 28.
So you have to think giving albumin with diuretics, because if no albumin, there is no, there is impaired first semi delivery to nephrons, so diuretics will not help or not will work. So we're giving albumin with diuretics. His edematous, definitely there is an interstitial edema all over, and he's hypoalbuminemic with his acute illness and sickness. So albumin was given, diuretics was given, and he passed the test, and he was stable. So is it the time that we have to go with aggressive diuresis at that point? What's the most appropriate next step? If you know that his X-ray showed better airspace disease, okay, and yet he's more hypernatremic now with more diuretics, and there is an evidence of metabolic alkalosis. So what's next? Should you look for sign of hypoperfusion, think to hold diuretics, dynamic measures, or consider all above? You're going to do all above?
There is no other.
So you have, he's almost going to a negative side. So should you continue to monitor the sign of hypoperfusion, or just stop diuretics? You don't have to diurese him any further. And you do the dynamic measures to make sure he's fluid responsive or not.
So what is the cumulative fluid balance?
It was 4 liters.
It was
and
4
go down
liters.
To 2,
Yeah.
to almost neutral to negative.
Okay.
Okay? And he was hypernatremic and alkalemic. So we're thinking he's toward, I mean, volume intravascular contracture. Okay? And if you see his chest X-ray, compare his chest X-ray from previous X-rays. Radiologically, I mean, it's more clearer. So we diuresed him, he's negative, and we're able to extubate him successfully after that.
Minus 1 minute.
Yeah. So based on your answer, what you would consider at that point, stopping treating patients? When would you stop treating this patient fluid accumulation syndrome? Sorry, just, I don't know. There's no MCQs here.
So we stop treating, well, when FAS has resolved, so when there is no longer fluid accumulation and
Which
there is
is
no
logical.
negative impact on organ function. So here, I think at the end you managed well, despite the odds. Despite, so you can see that patients can take a lot. You can do a lot of things wrong, but patients will survive, unless they decide that they don't want to survive.
Because we have a lot of septic patients, we have a lot of variety of septic, but intentionally we brought this case to trigger, to make sure you maintain on road spaces, and you go with a stepwise approach, and you assess as per literature recommendation, and you grade talk and support.
Thank you.
Thank
Abdulaziz.
you.
Thanks for the audience. So it's my great, great pleasure to invite the president of the World Federations of Intensive Care and Critical Care Societies of the World, Professor Jorge Dallo, my good friend. Nice to have you here for the closing lecture on artificial intelligence and how this will help us to solve all these difficult problems. Please.
Well, good afternoon, everyone. And first of all, it's a great honor to meet with you guys today. And of course, after you spend a whole morning with this master in fluid and therapy, what I can say more. I'm really admire the work that Dr. Malbrain and Dr. Monet does. I really enjoy listening to their presentations. And as well as I believe you enjoyed the whole morning and this exchange of ideas that always open the opportunity to new learning. I mean, and this more than is a provocative lecture because, of course, there are too much to do and also to learn about what is going to happen in the future with artificial intelligence. I mean that this is essentially what we are going to cover in the next few minutes. It's artificial intelligence and fluids, a vision for the future. And as you know already, this fight between what is the best options and everything. My conflict of interest, I am the co-chair for the Surviving Sepsis campaign for the low resource setting. That is important. And also I'm the co-founder of Technosepsis, who is also a meeting that we explore technologies, and the first Technosepsis meeting is scheduled to happen in Dubai by the middle of February. Mean that this is my ICU in Belize. I'm from Belize, Central America. And you already spent the whole day essentially learning from the professors on what are the different complexities and also the current limitations when we are managing fluids in a patient on a regular basis. You already review the variability in hemodynamic response, and we know already that it will depend on how each individual patient is going to respond, the background, and also we know already that most of these tendencies is to do a personalized approach of manage of fluids and also manage patients in ICU. We also learned during the course of the day what is going to be the problems if we delay treatment and what should be the potential complications if we do a suboptimal management of this type of patients. In any case, either if you are in a fancy facility or if you have just minimal resources, what I can say, I don't care if your friend has a flight simulator. You are going to learn to fly on your own. Whatever resources you have, you need to apply. Up to now, we you don't have, I can tell you, and I'm sure Dr. Malbrain can agree with me, that there are no a monitor that I can say this is a standardized monitor and this is the monitor I recommend. Unfortunately, this is not the case as yet. We probably go over there. I mean that what we are going to see and what is happening already with technology is essentially trying to help us on a decision-making process. I mean that trying to transform the way we think, and with different options, as you already reviewed and went into the monitors and trying to see how we can integrate all this data. As every day, you know, we have different technologies, smart beds that can give you the amount of urine per hour. It can basically try to detect the different events that happen with a patient in a given moment, and then we can try to analyze how we are going to approach. But of course, those technologies are not available for everyone, and of course, it's expensive. The technology, unfortunately, despite that we live in the age of technology, in the state to be more affordable, it became more expensive. I mean that we're trying to integrate all this information, trying to collect the information that we put in our database for patients and trying to have some predictive analytics as how these patients potentially are going to benefit. And most importantly, the time for ICU is important, and the longest we wait, then we are going to face more complications. And you already went through them during the day and analyze and see all these different cases that you already discussed during the course of the day. I mean that what is the idea how we are going to advance on progress in the age of technology and the phase and the age of artificial intelligence? Well, we're trying to see how we are going to have those fluid responsiveness tests, how these machines are going to provide us with the information that we need with data analysis and see how we can improve our work. At the end of the day, the most important thing and the ultimate goal for us is to improve outcomes, reduce mortality. And then all these technologies are important, but at the end of the day, as we mentioned, as we see, we have all information, we have technologies, and we have monitors that give you different information, and the most important is is how you are going to apply the information that you are going to collect to the patient and into your daily practice. I mean that we see how the precision medicine and the personalized medicine is essentially taking over. We see already that definitely if you are going to give fluids to Jorge Hidalgo and you are going to give fluids to Dr. Malbrain, you see the difference in sizes. No, I'm a short man, probably, and also I have probably different response and different medical background that definitely probably I will need a different approach if you're going to treat someone with these characteristics. I mean, we know already that we need to be and treat everybody in an individual phase. We know that also how this different equipment and the artificial intelligence is going to help us to do some dynamic fluid adjustment on a real time, in a real moment. Over time, our patients are dying and we need to act immediately and don't wait too long. And of course, with in the new century, we hope that we already will have the quantum computer applied to artificial intelligence, where the velocity and the speed of the information is going to be critical. I mean that those are the things to come. We are still already fighting if ChatGPT and DeepSeek is what is better, and also just to mention things. No, I mean that it's difficult to say what technology is better than other. The most important thing, as I mentioned, is how we are going to apply the information that we are collecting for the best of our patients. I mean, the other important aspect also that we need to remember is that who owns the information, who owns the data. I mean that we collect all this information, and then data security and privacy are key. I mean that even if those technologies that we know already are impossible to touch, and we see that they are breaking in those systems that are basically, the people invest a lot of money. I mean, that what we can do with technologies that are really, really in developing process, then how we are going to guarantee the privacy of our patient. I mean, that is important, and it's an ethical dilemma when we're touching bases on all those things. The artificial chasm and the gap who exists between the development and clinical application. I mean that we are evolving so quickly. I mean that we have already this company that is offers that this monitor is going to be the best monitor for the following 2 or 3 years. But technology is evolving too quickly that we already, when we buy this technology, it's a new technology already available, and somebody is already selling it to you in a different company. I mean that this battle of technology is important because we need to know, and as we are going to review in a few slides at the end, that we definitely need to work with the information that we have. And of course, the most important thing is that we need to create and give our patients trust. They need to trust that we are doing the best for them. I mean that the other aspect is, as I mentioned in the beginning, is the access. I mean that we need to have technologies that are equitable. And also, as World Federation, we are trying to promote that technologies can be accessible for everyone in the low resource setting. But this is not the case. Technology is expensive, and of course, at the end of the day, these expenses are going to our patient. I mean that's the thing. But I mean that the equitable global access to these technologies is something that also we are advocating for. It's difficult, but we need to fight. That's where we are. Of course, we know that the robotic integration and these evolving technologies, always thinking that if a robot is going to replace our work, and the most important thing is that whatever we do is, whatever information we provide to all these technologies is that essentially works for. I mean that it's important for us that we need to know that we are the ones that are providing the information, we are the ones that are analyzing the information and trying to do the best with that. I mean that we see already several advances on the predictive analytics, and then we'll see this, we will analyze this study very quickly. We don't have too much time. You are already tired, but just one of the first studies that essentially trying to apply artificial intelligence as a tool to predict fluid requirement. And then the idea of the study was to prove the concept of assessing artificial intelligence capabilities to predict fluid needs. I mean that the objective was develop a test on artificial intelligence tool to predict the individualized fluid requirements. And we utilize patient data from electronic health records to train predictive models and trying to incorporate machine learning algorithm that they use in this study. I mean that the impact of this study was the A model demonstrate high accuracy in predictive fluids. Of course, this was at the very beginning, and the concept was validated, but of course, at that point, and as today, we need more large clinical trials to validate the utility. We know that at some point, and we know that some of the information is really useful, but we need to have more clinical and big clinical trials to make a more important decision. Machine learning methods to improve bedside fluid responsiveness, especially for patients that we see every day with severe sepsis and septic shock. This is an observational study. Focus is using machine learning to improve the bedside prediction of fluid responsiveness in this type of patients. The idea was to enhance the fluid responsive prediction, and also it was an observational study to develop and validate algorithm for clinical application. Accuracy demonstrate high sensitivity and specificity in predicting fluid responsive. The clinical impact improved bedside decision making for fluid. And of course, again, we need to have more and more studies. The study overview, comparing machine learning, and of course, in this study, trying to use traditional regression methods for fluid ICU and prediction in ICU in this other study that was published in 2023 for SICORA. The significance was to highlight artificial intelligence role in enhancing early detection and management of fluid overload. Evaluate the machine learning against regression for predicting fluid, and the approach was analyze ICU patient data using, of course, the machine learning models included XBoost. That is, today, XBoost is one of the most important learning tools that we have, including the severity and illness of the score for medication data. Performance, then we see the different models, and also the severity score and medication data were critical for accurate decision, and the clinical relevance is that the machine learning offers an scalable approach to identify at risk of these patients in an early stages. Meaning that implications for ICU practice, artificial intelligence enhancing fluid management, of course, early identification of the patient at risk. The other important thing is the data has driven over the way we practice in terms of patients with septic shock, and the potential possibility to improve outcomes and reduce mortalities in the ICU. This needs to be integrated with our clinical workflow and to be able to apply as quickly as possible as we are developing and the patients are there. Challenges and opportunity. We already mentioned data quality. We need to rely on high quality data sets, limits his application, and of course the resource limited settings is important, especially for countries with low resources. We need, of course, a broader validation across diverse ICUs, and we need, of course, more research. Machine learning in ICU fluids, and then we see all these machine learning models, XBoost, we already mentioned that, and also the future directions and the importance of that. I mean that we already saw some of the technologies, the Acumen technology to enhance and to provide us with more tools to improve the patient management. I believe you reviewed some of the technologies. I'm not going to go into detail. But the idea is that essentially those technologies are offering us the opportunity to have better information to make clinical decisions in a better way and a more rapid way to improve outcomes. For time, I'm going to go a little bit more quickly. Then fluid management in the 22nd century. Well, we already know that the idea for this technology is to make more autonomous decisions, meaning that we will see how the machines' autonomy are going to create and probably give us a more quicker response to have a more rapid response. Nanotechnology integration probably will be able to inject those nanobits to our patients and to be able to analyze information on a real time and have a better decision-making capacity. And we already mentioned the quantum computed system that is going to speed the process of information analyzed in a more quicker way. Of course, the artificial intelligence is revolutionizing the technology and the care we do for our patients. We have digital twins, artificial intelligence that will create a real-time patient simulation for fluid management and prediction. We, of course, need to have a preventive intervention, meaning that we are going to be able, or that's the idea, to intervene in an early stages to prevent complications. And one more thing, and I'm insisting on that, global access and equity is something that we need to advocate and to fight to be able to have these technologies available for everyone, ideally. But of course, that is some of the things that we need to advocate every time. And of course, it will serve as a real-time collaborator in the decision-making of all these good discussions that you already have. It will to provide us with information to help us to improve our decision, see how all we are going to be able to connect all this with our electronic database in the ICU patients. And of course, we are moving more to precision and to personalized medicine. The artificial intelligence as a catalyst, it will redefine fluid therapy by offering unmatched precision and personalized. Of course, we need to have always our best interests as our patient, and everything needs to be patient-centered. We need to advocate for our patients. We advocate for them, and we need to collaborate with innovation, and especially to have the opportunity to have an organizational IB like Dr. Malbrain organization and Dr. Monet that is essentially help us and teaching us and take us step by step how we, in a better way, are able to manage our patient. This is really one of the tools that I really admire and enjoy to see the step-of-step management for fluids. In any case, you have the resources, let's make the best use of them. And with that, I invite you to join us in our Congress, World Congress in Vancouver in September this year. Dr. Monet and Dr. Malbrain, thank you, and it's really an honor and pleasure to be with you guys.
Thank you so much, Jorge. I have here a signed copy of the 1 million download book, and I have some Belgian waffles in the form of cookies. Could you take a picture of maybe short?
Maybe, yeah, maybe here's my time.
Yeah, okay. And now everyone can get ready for the examination. Yes, yes, yes. You have a comment? Yes.
Do you think this machine is intelligent? Who is the intelligent here?
The human.
Who created them, or the machine itself?
No, we are the humans.
I'm really biased by this name. For myself, I'll call it AX, the artificial health.
Yes.
Now, if I want to be extrinsic, I would say, in practice, yes, artificial speaking sometimes. The data we give, the data we do. Being faster doesn't mean it doesn't make it easy. That's my point.
I agree totally. As I mentioned in my talk, these machines are going to provide us information, and the machine essentially provides us with information, and it's us and the way how we are use the information that it will make a difference.
So the intelligent part
It's the humans.
the way you put here a human, an artificial man standing, this is the intelligent part. I think, why don't we call it the AX?
And remember, that is the discussion that they usually have, is the robots are going to replace us, and the answer is no. I believe that we are the intelligent one, and us as that we are going to use the information and use it in the best interest for our patients.
Future will tell. So we'll see if you're here still in 100 years or we've vanished because the computers took over. It's exciting. Thank you so much, Jorge. And now, ladies and gentlemen, the final part, the exam, to get the certificate to be a fluid champion. Okay, so let's start. The sooner we get over with, the better. So joinmenti.com, it's again the first Menti that we had this morning. 43, 46, 46, 42. 43, 46, 46, 42. That's a good number. And I think there is a team here from Kuwait who wants to become a center of excellence. Where are you guys? The Kuwaiti team. Okay, we have a pharmacist, we have doctor, dietitian, and a nurse. Okay. So if they pass as a team, you could apply to become a center of excellence if you're a fluid champion taking the online course. So everyone there, I see 18 people joining, 20. Okay, you can always join later. Okay. So now we wait for everyone to join. We have 28 ready. You can use a nickname, you can use an avatar, whatever you want. Is everyone who wants to do the exam ready? Who is struggling to get online? No one is struggling? Okay, so we're gonna start. Let's go. So the faster you answer, the more points you get. Very important. What comes closest to the sodium content of saline? Is it 140, 45, 50, 55? The sodium content of saline. We showed it many times on different slides. 5 seconds, vote now, quick, quick, quick. More points if you vote quick. All right, so it's 154, okay? So 155 is closest, we have 4 having the right answer. Okay, get ready for the next question. Everyone ready? Okay, here we go. So remember, faster, more points. Replacement fluid from a high output ileostomy resembles most. What do you think? Is it saline, glucose, isotonic balanced, or hypotonic saline and dextrose? Just use your common sense. Okay, 3 seconds, vote now, quick, quick. Okay, correct. So, isotonic balanced resembles best. Of course, if you would vomit, then saline would be the best option. Question 3, everyone ready? Yes, here we go. What comes close to the glucose content of a balanced isotonic resuscitation fluid? Remember the bottles with the intra-extracellular water? So after 1 hour, oh, no, sorry. This is the glucose content of a balanced solution. Sorry. Yep. I'm confusing you. 3 seconds. How many glucose in isotonic resuscitation solutions? Yeah, it's 0, of course. When there is glucose, we consider it maintenance. So no glucose for resuscitation. Okay, question 4. Remember the faster rhythm. What is the ideal sit? Yeah, we mentioned this a couple of times. So I told you the sit of saline, and afterwards we discussed the optimal strong ion difference to keep pH neutral. 5 seconds, vote now, quick. Okay, very good, very good. It's around 24, 26, that's nice. Plasma-Lyte has 50. Okay, everyone ready? And I think within a while we will see a leaderboard. We're gonna see who's in the lead. Balanced solutions are the resuscitation fluid of choice, except 4. Is it AKI, but there are no nephrologists, are there? No. 5 seconds, vote now, quick, quick. Get more points. 2 seconds. Stop voting. Okay, excellent. So in TBI, we can use saline according to this systematic review. Question 6. Everyone ready? We lost someone? We were 34. Who is not connected? No? Yes? Okay. Maybe someone gave up. So we talked about the ideal maintenance solution. If you remember one of my first slides on the IFAT in Valencia, humans make mistakes. So is it isotonic, hypertonic, balanced, saline? 5 seconds, vote now, quick. Remember the NICE guidelines, hypertonic, balanced, excellent, excellent. This is the best response to the answer, yeah. So everyone paid very good attention today. 32, where is 33 and 34? Who is giving up? Come on, join again. Nothing is lost. What is the strong ion difference of saline? So basically it's the sodium minus the chloride. 10 seconds, vote now, quick. And the team, you can act as a team, of course, but the others should do it by themselves. Okay, it's actually 0. 154 minus 154 is 0. Question 8, and I think then we will have a leaderboard, so we will know, 33, okay. Oh no, 32, okay. So in a normal adult, insensible losses, we didn't talk about that too much, but this is common knowledge. So what are the insensible losses in a normal individual? So not on the ventilator or so just a regular person. What comes closer to it? Is it 100 up to almost 1 liter? Vote now. Okay, no, it's about 900. Half a liter would be if he's on the ventilator with moisturization. Okay, now we're gonna know dramatic music, drums playing in the back. Then you get extra points, the fastest. We have in third position, Heba. Where is Heba? Heba, congratulations, okay. In position 2, Sijo. Okay, congratulations, Sijo. But in first position and the fastest, Magda. Okay, give her an applause. But nothing has been decided. There's a lot of things, a lot of points to gain. Come on. And where is Kuwait? Where is, come on, where are you? Vote. Okay, serious now. Question 9. What is the most important parameter to diagnose hypovolemia, volemia status? Think first. Hypovolemia, remember, what is preload? Actin, myosin, stretch, whatever. Five seconds, vote now, quick. Here you go. Of course, these are not good preload parameters, they are just rubbish. And the passive leg raising doesn't tell you anything about preload. Okay, forget the question. But don't get misled if there is another question similar like that, okay? Yeah, it was a naughty question, I agree. Following are indicators to start vasopresses, except. We discussed a lot about early vasopresses. Okay. 5 seconds, vote now. We talked about low diastolic blood pressure. Yep, that's good. Lactate of 2 seems normal to me. Unless there is a lactate hangover somewhere with lactate stuck in the mesenteric veins because of acute mesenteric ischemia, but the others clearly are a good indication. Okay, but if everyone got the question right, there is no change in the top three, you know. The stressed volume. Remember the video with the myths and misunderstandings. So the stressed volume is what? 20, 30, 40, 50%. You have 5 seconds, vote now. Okay, excellent. There's about 30%, the rest is unstressed. You can recruit it with the vasopressors. Very good. Almost halfway. And remember what's on stake, eh? A copy of the book. What does not give an idea of the perfusion status? Lactate, sensorium, urine output, pace deficit, heart rate. 5 seconds, vote now. Quick, more points. 1 second, stop voting. Okay, good. Heart rate doesn't tell me anything, even if the patient is on beta blockers. So remember what's on stake. Eh? I have some Belgian chocolates. I will put them with the prizes. So the last one or the first one, if he prefers the chocolates, can choose them. Question 13. What has the best sensitivity for fluid responsiveness? Lecture of Professor Monet. SVV, PPV, SPV, CRT. Which one is best? The best area under the curve. 5 seconds, vote now, quick. Okay, excellent. PPV is best. Although it's a bit counterintuitive because fluid responsive is an increase in stroke volume, you would suspect that SVV would be better, but if there is dampening of the curve, probably that's the reason. SPV is systolic pressure variation. We didn't talk about that with delta up, delta down. CRT is capillary refill time. It is not a good indicator for fluid responsiveness. Question 14. So PPV is best, but what is the threshold to define fluid responsiveness? 5, 10, 15, 20%. Pick your number, but do it fast. Okay, 5 seconds, vote now. 1 second, stop. PPV is 15. 15. Okay. Let's see if Magda is still in the lead. Oh yeah, there's nothing happening. No change. Wait. Here you go. Oh. There's no change. Okay. Okay, so everyone did the same as during the first round. So you see, maybe everything is already decided. So you will have to do better to get your chance to win a signed book or Belgian chocolates. That's what's on stake. Okay, third part, according to the rows. And after the final part, we will know the winner. What is true regarding end expiratory occlusion test? Professor Monet, lecture on fluid responsiveness. Should it last 5 seconds? Is the threshold 5? Can it be assessed with pulse pressure? Or should it be assessed with echocardiography? 5 seconds, vote now, quick. Okay, the threshold is 5. You agree, it's your question.
Indeed. Pulse pressure, in fact, it may be possible. The problem is that you must have an automated display of pulse pressure, which is not available. At best, it is with cardiac output, indeed. And the threshold is 5%.
Okay. And the duration? 45? Oh. All right. What passive leg raising delta cardiac cardiac output threshold defines fluid responsiveness. So passive leg raising. Yep. PPV was 15, and expiratory occlusion was 5. So maybe 5, 10, 15, or 20. Pick your number, 5 seconds, fast, go, go, go. Okay, good, excellent. Question 17. What is the maximum recommended daily sodium intake? Remember the slide with the chips, you know, on the right-hand side down there. Is it 0.9, 1.5, 2.3, 3.5, or 7 grams? The dietitian will know. 5 seconds, vote now. How many sodium, free sodium do we need? Okay. 2.3 is enough. 1 bag of saline is 3.5. 1 bag is already too much. Question 18. And answer fast, so that we can have the group photo and finish this. Come on, quick. What comes close to the volume expansion effect of 1 liter saline after 1 hour? Okay. 50, 100, 250, 500, 1 liter. 10 seconds, vote now, quick. Remember the bottles, you know, the extracellular water. Okay, excellent. 250, 25, 30% for isotonic crystal. It's also for ringer, plasma light, but not for glucose. Question 19. What's the most important parameter to predict fluid unresponsiveness? Unresponsiveness. What can we do to test? Probably it's the same as fluid responsiveness. Professor Monet will tell us. It's the same question, okay. So now don't use other. This is just, Yes. The passive leg raising will tell you both. Fluid, Magda is losing it. Okay, now it's the chance to beat her. Oh, okay, but Heba, is Heba? You're getting close. Saijo, you have to do your best, okay? And then we have Zbitar. Where is Zbitar? Okay, good. And Lolo, funny names, okay. HA is human albumin. Where is the human albumin? Okay, that's it. Mohammed Fazal. Very nice to disclose your full name. Isra, okay. And then we have the Rose. Very nice nickname. And GTN. GTN stands for? Okay, it's a secret. And I think now we move on to the final part. 5 questions to go. Everyone ready? Okay. I hope there will be some changes at the top to make it exciting, but on the other hand, Magda deserves to win because... Yeah. So Pico measurement, long water 9, PVPI of 4. What would you do with that? Normal long water, 7 to 10. I don't know is never the right answer. Okay, that's good. So if long water is normal, we don't care about PVPI. Probably is the measurement error. Was a tricky question, I agree. Magda, you got it right? Okay. Question 21. The least measurable change for VTI, and we discussed it many times also during the case. 5, 10, 20, 30. Quick. 5 seconds. Vote now. Stop voting. Okay. Yeah, 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 but hey, that's life. Almost there. Which limitation evaluation of PPV test is not correct? Arrhythmia, low tidal volume, high lung compliance, RV failure, abdominal hypertension. Abdominal hypertension is always right. If there is a question, the answer is always abdominal hypertension. 3 seconds, vote now. Quick, quick, quick. Yeah. It's a limitation. It's a double negation. Yep. You lost it? Okay. Magda, you got it right? Okay. Almost there. And then we're going to have the group photo. Is it safe to give a balanced fluid with potassium of 5 in a patient with renal insufficiency? Yes, with a but. No, yes, maybe. Remember the nephrologist who was not in the room. 5 seconds, vote now. Okay, it's perfectly safe. A balanced solution, even if it contains potassium, will lower the potassium because of the SIT effect. Before last question. In a stable edematous fluid overloaded patient, what is the best approach? Watchful waiting, continuous furosemide stress test, spironolactone, albumin. Pick your choice. I think we discussed it many times. 5 seconds, vote now. Okay. Just do the furosemide stress test and see if your patient is ready for de-resuscitation. Okay. Looks like a nice background. Looks like a camel to me. We are in the country of camels. The premature hump seen on this curve can occur in all except pulmonary embolism, ARDS, autopeep, atelectasis, hypovolemia, and a very high peep. Oh, it's easy. 5 seconds. Vote now. Okay. Atelectasis. Because all the others may create zone 1, 2, 3 of west excursions. You got it right, Magda? Okay. And I think now we are there. So remember, if you're signing up here as a team, you can become, or you can file an application for a Center of Excellence. Can we have some dramatic drum music? Can you play a sound? Because after this, we will identify the winner. If you want to stay more connected with the Fluid Academy, you can leave your email. We just wait for the dramatic music to be ready. And otherwise, we will have to do like this. Music? I'm giving you a lot of stress, the technical team. Drums. Come on. YouTube, drum music. Now, dramatic music. Even louder. There is some music. What's that?
Oh my god.
Okay, this is fine as well. Okay, so the winner of the IFAT Mini during the International PANARAP Critical Care Medicine Society meeting of 2025 is... Oh, Saijo! Congratulations. So I have here 6 books and 1 chocolate, which means that we can identify 7 winners. But for the Kuwaiti team and organizers,
the goodness within?
is your name within the
Grab a bar
first
to
7?
start.
Somewhere? Nowhere? Okay, but I will reserve a book for the pharmacist. As they were organizing also, I will give it to you. I will sign it afterwards. Okay, so we are left with 5 books and chocolates. Do you like chocolates or books? Books. Okay, so you're the winner. Look at him, remember him. But before we go, no. First we go down to the top. You stay here. Yeah. So 1, 2, 3, 4, 5. Lolo is in position 5. Step forward. And I'm even wrong, but after, behind the flower, there is number 6. You can have the chocolate. Can you see who you are? Can you see on the smartphone? You're in what position? No. Is it Magda? It's Magda. Ah, who is number 6? You have a number. Who is not? You're number 6. You're number 6? Okay, come on. What's your name? Okay. You can choose later book or chocolates. Okay, so position 6, a big applause. Come here. Well, I think everyone wants the book. Yes, I take. So, yeah, but you're 6, so you get the chocolates. Okay?
Thank you.
Okay, can we have a photo, Abdulaziz? Abdulaziz, photo with Xavier, with the IFAT cup. Quick, because we're gonna go. We want to... Where you from? What was your secret?
Sabah BICU.
And the secret to be the 5th winner?
I don't know.
No cheating?
No, nothing.
You just paid attention to the lectures. Congratulations. Okay, stay here. We have a group photo of all the winners. Zbitar. Where is Zbitar? Please. Congratulations. Where are you from? What was the secret?
I don't know.
You have to say, I paid very much attention to.
Yeah.
Okay. Stay here for the group photo. Then we have Magda. Okay, Magda, position 3. Is a podium place. Excellent. A chocolate, you get a book.
I need chocolate and book.
No, it's chocolate or book.
Thank you very much.
You can try to change with that gentleman.
This is. Thank you.
Okay, thank you. Stay there. Then we have Heba. Over here. Congratulations. Certainly you made the jump. I just listened to a lecture that it was nice. Okay. Congratulations. Group photo with the winners. Come here. Abdulaziz. Speaker Georgie is left. Okay. For the winners here, and then everyone gets ready for the group photo. Okay. So we do thumbs up, thumbs up, thumbs up. Picture. Then we do show me the money. Show me the money. The heart, sorry, the heart. And now the crazy one. 1, 2, 3, fluids! Okay. Everyone, please come on stage. Group photo. Some over here, some on top. Yes. One serious.